grew up in a place called Rockaway Beach. It was the west part of Long Island. Long Island is Queens and Brooklyn. And right below Queens and Brooklyn is this narrow slip of land that closes off Jamaica Bay. It's called the Peninsula. And it was only half a mile wide, and we're between Jamaica Bay on one side and the Atlantic Ocean on the other side, directly under the glide path for Kennedy Airport. So I grew up with a lot of airplanes. But it was, I grew up in an apartment. There were 6 buildings that made up our apartment complex, 6 floors on each one, 10 stories. I think there were 2 non-Jewish families. I grew up thinking the Jews made up 97% of the population. Wow. It wasn't until I got to college that I realized we were only 50%. So it was all the disadvantages of living in a big urban city and none of the advantages of living in New York, because it was still an hour and a half, 2 hours by subway into Manhattan. My mother would send me outside to play with the boys and play basketball and get some fresh air. I would walk through the junior high school athletic field, which was right next to our apartment complex, through the next apartment complex, and end up at the library, where I would sit in the air conditioning and read a book. I used to read a lot of science fiction when I was young. I don't recall reading a whole lot of nonfiction, so mostly science. I was a geek. I continue to be a geek, but so I read geeky things. I loved school. It was great fun. First of all, you never had to shoot a basketball except for that narrow window of gym class, and so I was very happy about that. And I always enjoyed learning, despite the fact that they found every way that you could make a book terrible, including taking a classic like Robinson Crusoe and going from person to person, have everybody read a page out loud. My God, what a way to ruin a book. But I still enjoyed it. For a while, I wanted to be a marine biologist. Then I took a marine biology course, and it was in high school, it was a lot of fun. We went out in Jamaica Bay. We used these big seine nets and brought in things. I got a seahorse from Jamaica Bay, which is very rare. So a lot of fun. Then we got on a boat and went actually out into the Atlantic Ocean. Then I decided marine biology was not for me. And I remember vividly standing in the lab in the boat. It actually was a research vessel. And all of a sudden noticing the rocking from side to side and noticing sort of a vaguely disquiet. And so that's when I decided it wasn't for me. When I went to college, I wanted to be a molecular biologist or a physical chemist, something involving sort of 3-dimensional structures of stuff, biochemistry, the idea of how structure influences function. And I think I just sort of fell in with the wrong crowd with a bunch of pre-meds. It wasn't an epiphany. It wasn't a day that I woke up and, I didn't break my leg and then, the orthopedic surgeon who said it, convinced me I wanted to be a doctor. I didn't have somebody in my life who got terribly ill and was saved. It just was an evolution. I liked biology. I liked what I was doing. I was in with a crowd of people who did it. It seemed a perfectly reasonable thing to do. I am a solitary person. I don't require people around. I like people, but I'm not comfortable in big crowds. That's part of the reason I went to libraries, because I didn't want to be among a bunch of guys. I'd rather be by myself, and that's persisted. So I'm shy. It allows me the freedom to be myself and to think about things and to read and to sort of formulate ideas. I don't have to be in a crowd all the time. Extroverts sort of get their energy from the crowd, and I get my energy from being by myself. So that fits in nice with the intellectual part of what I do. It is difficult sometimes to take that and put that as being an IRB chair or any person who leads a group. So I have developed techniques to get through that. And consider myself to be a good diplomat, to be able to talk to people. If I've got an agenda, I don't do very well at walking up to somebody and striking up a conversation. I certainly don't do very well walking up to somebody, I come here often, that kind of thing. But even at these meetings where I know a lot of people, I'm sometimes hesitant to walk up to people and say hello, because at least part of the brain is saying they'd rather be talking to somebody else. And I realize that's a very dysfunctional part of the brain, but it's a process. By the time I'm 90 or so, I'll get over that. But I'm rather proud of the fact that my parents were liberals. And liberal has become an insult now. And they taught us, me and my sister, the importance of social justice. And they taught us that by living it. And so some of the formative memories I have are going to rallies. I remember being in a high school auditorium where we were listening to a candidate who was clearly going to lose, and there was a lot of ruckus in the room and people yelling at him. And I remember being scared and saying to my dad, let's leave before there's a problem. He said, no, we have to be here because we've got to show our support. And I went down to the big peace rally in Washington, the Vietnam peace rally in Washington. We got up at like 3 o'clock in the morning, got on a bus, drove down to Washington. We're with that incredible crowd of people there, and then drove back to New York the same day. I remember, another evidence I remember was we were parked on the main street in our little town, Far Rockaway, and my mother was off doing something. My dad and I were in the car, and some homeless guy, I guess, knocks on the car window. My dad rolls down the window, and the guy says, "Have you got a buck? I'm hungry." And my dad sort of waved him off, and he walked on. And we started talking again, and about 10 seconds later, my dad said, "Hang on a second." He got out of the car, he chased the guy down, and he gave him a buck. And he came back in the car, and I said, "What'd you do?" He said, "He needed the buck more than I did." That struck me. So yes, those are formative things. That didn't turn me into a physician, although maybe it did, because you need to have some sort of empathy. You need to be, to understand other people's problems to do that well. But it certainly influenced me in my transition from being a physician and a clinical researcher to being, I fancy myself a research ethicist. I wish I had the initials after my name, but I fancy myself that. There was a fascinating patient that had, I don't even remember the details, but who had a disease, and this is when I was either a fellow or just starting as the junior faculty member, and we were going to do a bone marrow aspirate on this kid anyway. So I didn't stick a needle into his hip just for research, but I drew a little bit extra bone marrow to do these tests. Didn't think about asking the mom, didn't think about asking the IRB, just, you're in there anyway, well, 2 cc's, who cares? And it wasn't until quite some time later that I realized, oh my God, that was wrong. What I remember about my first exposure to the IRB was sitting in my office as now an assistant professor, trying to figure out what I wanted to do with my life. I made the decision I wanted to do something academic. I wasn't out in private practice, so I wanted to do something academic, and I needed to find a niche. And bone marrow transplant was going to be the niche, but I had to figure out what aspect of it, how I would make my, a mark on. And I get this phone, and I'm sitting there minding my own business, thinking about these deep, personal thoughts, and I get this phone call from Ernie Prentice. And at the time, Ernie was the chair of the IRB. And he also was practically the only IRB. But no, he was the chair of the IRB, and he was also the head administrator for the IRB. And he said, well, I hear you're an oncologist. We do a lot of oncology research. We'd like to have you come on the IRB. I said, I'm really not interested in that sort of stuff. And he said, just for 3 years. I said, no, I really don't. I don't want to do it all. The 3 years is not going to encourage me to do it. So I'm not interested. He said, it'll be interesting. You'll learn lots of stuff on it. You'll be able to help people, and you'll learn something. It'll be good for you. I said, no, I'm still not interested. Just 3 years. I said, not all right. If it'll get you off the board, I'll agree for 1 year. Okay. So he said, okay, fine, 3 years then. And that was 25 or so, however many years later. And he was absolutely right. It was the very Jewish tendency of arguing sometimes for the sake of arguing. People will correct me and say, no, we're not arguing, we're discussing. No, we're not, we're arguing. When you wave a chicken leg at somebody while you're making a point, it's an argument. It's not always a bad argument, but there's that great scene from the movie Annie Hall that contrasts Woody's family with Annie Hall's family. And in Woody's family, they're doing that. They're yelling at each other. They're gesturing. That's the way my family conversed. And that's the way I've always looked. And that's one of the things I loved about it was intellectually satisfying. We could argue about things just for the sake of arguing, but also important things. And we were arguing about things that meant something to me. We weren't arguing, I would have been happy arguing for the sake of arguing, but I was actually arguing about what's the best way to respect somebody and what's the best way to minimize the harm that might come to that person. These were important things. These are the things my parents taught me and that my parents lived, is respect. And so here I had an opportunity to argue about, to do something about respect, but also to argue about it in a forum and be able to wave a chicken leg at somebody. I've loved being a pediatric oncologist. I mean, it's a great, when I introduced that as my job, everybody, it always ends a conversation. Oh, what a terrible, horrible job. And so I've sort of developed a stock answer, but it really is true. And I say, look, in pediatric oncology, we take the worst possible situation. This is a mother whose just been told her kid has cancer, the big C, and all the implications of that. And I'm able to say, look, the most common disease we see is acute lymphoblastic leukemia, and we cure 85 to 95% of those people. So I'm able to go into a room with a mom who's just, their world has just ended, and say to them, we have a 95% chance of curing your kid. You tell me a better job than that. So I've loved that part of it. And yeah, I'm glossing over the unpleasant parts of it, but there are unpleasant parts of life, and certainly plenty of unpleasant parts of medicine. And I've loved that part of it, and I feel like I've made a difference in that part also. So I love wearing that hat. I even like the clinical investigator part of it because I feel like I fed into what made that go from, curing less than 10% to now more than 90%. So I've enjoyed that part of it as well. I get the part I love about the IRB stuff, again, is we don't get that many, in the IRB stuff, we don't cure people. We don't even have that many wonderful moments where you save something. It's just a steady, constant feeling like you're doing something important, maybe something that doesn't have a lot of feedback. There isn't that aha moment. There isn't those times that the fireworks go off. There are some. There are some times when you say something to an investigator or somebody and they have an epiphany and they say, oh, you're right. That's right. That is a better way of doing it, that you feel really good you've done something. But usually you don't feel like you're doing something. It has to come from inside. You have to feel like this is important. It stands for something important. And even though there isn't a fireworks moment, it's still important. The only way that perhaps you can take care of a group of predominantly physicians is by being louder than they are and perhaps ruder than they are. I'm less shy with people I know. And there's a difference, I think, and I've thought about this a lot, between being an introvert doesn't mean you can't be loud in a crowd. It means that you have to go and find time to yourself to sort of recharge. So I can do okay in a crowd. I do a whole lot better in a crowd of people I know, and I know all the people in the IRB. So I know my interactions with them. But I'm not a gregarious, outgoing person who can walk into a room and become the center of attention. I'm the guy. Yeah. Well, and perhaps that's part of it. I do much better. I met somebody this afternoon who I didn't know, and normally that's sort of a little bit of but we got into an argument. And then I did just fine because it gives me something to do with my hands, but it also it's a connection. I can back and forth with somebody. What I try to get into an IRB meeting is inclusiveness, is getting everybody to speak. And it doesn't work, but that's the goal. Many of our meetings last for far longer than they're supposed to. And people have told me, these meetings would be faster if you would just, move the conversation along and, cut somebody off. And if you're going to be there for a 4-hour meeting, the way to do that is, the way I would do that is because I have some fun talking. And if you cut people off, if you don't give them their say, in addition to it not being fair to not give somebody their say, but it's also not fun for them if they can't be on the floor. So I try to include people and I try to let them say their piece. And sometimes that perhaps goes over the edge and the meeting lasts too long, but it is what it is. I've worked with a number of spectacular community members, and a lot of it comes from within them. I think in many cases with those people, all an IRB chair has to do is be prepared to come to the aid, to come to defense, because there are, physicians in general. I feel very high. I think very highly of most physicians, but their training is to be right. And that's what you want from your doctor. You don't want your doctor to be sitting there saying, what am I going to do? What am I going to do? You want them to know what to do. And that sometimes flows over into things that perhaps they don't really know what to do. So one thing that's commonly said about physicians is they're often wrong, but they're never in doubt. So you have, as an IRB chair, with a community member is already strong, all you have to be prepared to do is defend him or her if they come up against another, a stronger or a louder physician or a louder non-community member. With the other ones, it's sometimes very hard to get them to speak in a group. And in many cases, the right answer to that is to say, maybe this is not for you. Sometimes a good compromise is to talk to them offline. And so I tend, partly because I don't sit very well, but I'll wander around the room and I'll stop behind a community member and say, what do you think of this? Or did you get your say on that? And then, if they say, well, I'm still a little bit unclear, then I can go back up to the front table and say, okay, we're going to go back to this point because so-and-so wants to comment. Comment, it's your turn now. And, then it's, to a certain extent, their responsibility to comment as well. The other so I think what you've got to do is authorize people to speak. I think it helps also, although it's a very hard thing to do, to force people to speak. But I think authorization works in most cases. Most people, being on an IRB is a voluntary thing. So you don't, if you're incapable of being in a room with physicians without being deferential, you're not going to agree to be on an IRB. The people who agree to be on an IRB and stay on an IRB are the ones who at least feel like, I know what's going on. I may be a little bit scared of saying it, in which case, having a chair that authorizes you to speak and defends you when you speak is all it takes. The fundamentals are there. We still talk a lot about risk. We talk a lot about benefit. We talk about the relationship. We talk a lot about informed consent, which is, to my mind, a misnomer. And I thank my friend Sue Fish for helping me understand it's not informed consent, it's informed decision making. Consent implies that that's going to be the end result. It is informed decision making. So we still talk about those things. What has changed has been the specifics of the research, the nuances. And I don't mean just nuances. I mean, there are some very significant differences between the big data kind of research we're seeing now and the stuff we saw 20 years ago. There are some very new paradigms. But by and large, most of it is the same. You default back to the same set of rules. Are the risks minimized? Are the risks justified by potential benefits to the subject and to society? Is informed consent being obtained? Informed decision-making being obtained? Is the selection of subjects equitable? Those apply to big data as to the nuanced kind of odd things we're doing now, as much as they did to the studies that were being done when I started. I think the reason, in most cases, that investigators and sponsors think of us as roadblocks is because they think that's just what we want to do, whereas the reason may be that we are particularly attuned to the regulations and to staying on the right side of the line. But we are, in many cases, roadblocks. We have forgotten that research is good and that most researchers are good. Nobody wants to hurt people. They want to produce for society. What we have to help them understand is that in the quest to do good science and do good things for society, you have to be careful that individual people aren't worse off for it. But nobody goes into it saying, I think I'm going to hurt somebody today. They go into it, they should go into saying, how am I going to do this and protect all my subjects? Use whatever word for protection you want. What in fact they often say is, this is important for society, and they sort of forget that the ends don't justify the means always. I think I would have to think long and hard to come up with a situation where the IRB stepped in and saved somebody's life. I just don't think those things happen very often. But there are lots of times when there are injustices being done to subjects that needn't be done. And so when a sponsor or an investigator says that if you become pregnant, we will follow you for the rest of your pregnancy. We'll take you off the study and we're going to follow you and your baby for the rest of their life to make sure. And they've got a good reason to do that. They want to know if the drug causes is a teratogen. But that's imposing, and it's not right. You know, you have a right to participate in research for exactly as long as you want to participate. And if you want to say, no, I don't want you to follow my baby, then that's it. And sometimes we get incredible pushback on that. So I can't think of a moment where I said, I've saved this person's life, but I can think of lots of moments where I've done something that would have imposed unduly on this person. Another pet one is where the research, the investigator, the sponsor will say, you have to donate this, these tissues. We're going to draw some extra blood that we're going to put away in the freezer, and we'll use it later if we think of something to use it for. And my answer to that is no, that you can't do that. You can ask my permission, and if you ask my permission, I might say yes or I might say no. But you still have to ask me. That's the proper thing to do. That's the respectful thing to do. Well, no. They're participating in the research. They've got to do this. No, it's not respectful. So I don't think that that's saving anybody's life, but I think there is benefit to help people be respectful of other people. That's what you taught your kids. I see parents do this all the time. Somebody hands them a lollipop. What do you say, Joey? You say thank you. You say please. That's respect. And that's sometimes what we have to teach investigators. And there's good in that. That's not a big fireworks minute, but that is an important minute when the result is that somebody's more respectful to a subject. Anything that has the potential for educating subjects about what they're going to be doing, what we're asking them to do, what they're doing out of the goodness of their hearts, that helps them understand is a good thing. There isn't a magic bullet out there. We have this fantasy that one of these days we're going to find the perfect tool and informed consent will be real. Informed decision making will be real. And I don't think that these tools are going to be necessarily that answer. I think the only answer is the hard answer, which is to say that the more time you as an investigator spend with the potential subject, the more likely they are to understand what it is that you're asking them to do. And the tools may make it incrementally better. Executive summaries make it better. A list of questions you ought to think about make it better. There's a very smart community member who taught me that. But they don't answer the question. The only thing that really makes it better is spending more time, is the investigator understanding that this is their responsibility, and the investigator understanding that consent is not an event. Consent is a process that starts from the moment you meet them, maybe even before, and continues for the whole duration of the research. And when investigators focus on that, the consent form as the event is when we lose them. And so unfortunately, the tools are aiming at that consent form. And they can maybe make the consent form better, but they don't help the process. We tend to think of it as a sharp line, because we tend to think in terms of the legal definition of the end of childhood, when majority occurs, when you're legally able to give your consent. When you're in Nebraska, the age of majority is 19. So when you're 18 years, 11 months, and 30 days, and you're 15 minutes until your birth date, you give your assent, and then 15 minutes later, all of a sudden, you're giving your consent. There's clearly no difference there. Assent is a concept that relates more to a person not being a truly autonomous agent who is able perhaps to say that this is something I'm willing to do, but because of a legal restriction or because of being on the spectrum of cognitive awareness, they're not really they're not really giving their full consent. So I see it as a spectrum. It's a real difficult concept. I'm more comfortable with the idea of what the difference is between between an adult consenting and a parent giving their permission, because there assent and consent are on a continuum. And the idea that it probably the safest thing is to say it occurs at a particular time, but it's a fallacy to think that you're giving assent when you're 18, but 15 minutes later when you turn 19, you can give consent. When you're asking for a child's permission, for a child to assent to participate in research, it becomes a definition thing. What you really want, what you're, I think, asking about is when is a child able to make that decision for themselves whether they want to participate or not? And at that, from a legal point of view, that happens at 19 when it goes assent to consent. But when is a child really able to make their own decision, whether we call it assent or consent or whatever it is? And there it's a very, very, very fuzzy line. It depends on what you think is the relevant factor in agreeing to something. Is it because you agree because you understand the consequences? Is it because you agree because you can name back the 8 required elements of consent? What is it that makes consent meaningful? When somebody says, I'll do it, what is it about that means, okay, you can do that, but you can't do that? And that's a real hard, fuzzy line. That's a real hard thing to define. That's a really fuzzy line. And it sort of depends on how you define when you're able to give assent. And it's also not an all or none situation. We tend to think of that in terms of people who have cognitive problems, that you can, there are certain decisions you can make and other decisions you can't make. You can decide whether you want coffee or tea, but you probably oughtn't to decide whether to buy a car or sell your house, right? The same thing could apply to children. You can perhaps decide you want to be in a research study which involves a single blood draw. You perhaps oughtn't, when you're 6, decide whether you want to be in a research study involving a phase 1 investigational drug. Someone who has a better understanding of the consequences of that, of the risk-benefit relationship, ought to be deciding that for you. It doesn't mean that your opinion is not important in that. So one of the things that I believe strongly about assent is that if you are going to ask for someone to assent, whether that's a child or somebody who's, you have questions about their cognitive ability, you better be prepared to accept what they say. And investigators sometimes have a little bit of trouble with this, and what we'll say, are you going to ask for so-and-so's assent? And yes, we will, because that's the right thing to do. What are you going to do if they say no? Well, then I'll default to their parents and let their parents decide. Well, that really is fairly disrespectful. If you think that their parents ought to decide for them, then don't ask them. Then don't ask the child, ask the parents. But it's somewhat disrespectful to say to somebody, what do you think? Nah, I'm not going to pay attention to that. I mean, you learn that when you're trying to dress your kids. If you give them a choice of A or B, accept the fact that they're going to say A or B. You can't really say, well, you chose A, but I think B is a better choice. If you think B is a better choice, that's what you dress them in. Investigators don't want to do bad things, but they don't often think through these things because they're thinking through things that are I don't understand, that are much more important. They're knowing the metabolism pathway of this drug. It's important to know. I don't know that. I happen to think about this stuff. So they can educate me and I can educate them. So I don't usually get pushback from that aspect of it. You asked a question also about dissent, and I think there's something to be said that's a very different thing than asking for assent. And one can say that I still want assent, and I'm going to respect your lack of assent, and that's different than saying I'm going to respect your active dissent. I think you ought to be far more willing to accept somebody's dissent than perhaps to ask them for assent. If the kid's kicking and screaming, that's different than just not asking them for their grudging acquiescence to participate. So I encourage investigators to consider what they're going to do, not only if the kid doesn't provide their active affirmative assent. But what can I do if they pull their arm back and they say, I don't want to do this? That is different. And it has to be respected also. I do clinical research. I participate in children's oncology group studies. The research is designed by somebody else, and we are participating investigators. The protocols come to us, and we try to enroll patients who are suitable candidates onto the research study. And I do that for a number of reasons. I do that wearing my, perhaps I shouldn't, but wearing my doctor's hat because I think they get better care on a clinical protocol. But then also wearing my scientist hat because I want to be able to say 5 years from now, you remember that disease that used to cure, there used to be a 10% survival rate, and it's up to 95. Well, because of the study we just did, it's now at 100%. I want to be a part of that. So I am able to say to people, I think you should participate in this research. But then I follow up by saying, but you don't have to, I'll still take care of you. And here are the risks and here are the benefits, and we have to both be agreed that you understand those things. The fact that I think the benefit exceeds the risk is nice, but it's not relevant. The only thing that's relevant is you think that. And you have to understand that there are alternatives. And you do not have to participate in this. And then you also have to understand, what I routinely say to parents is, look, you can say no now, we throw away the consent form and I never bring it up again, and I still take care of your kid. You can say yes and then go home and come back in the morning and say, I changed my mind, and I tear up the consent form, but I never bring it up again, and I take care of your kid. You can change your mind a week from now, a month from now, a year from now. Or I can change my mind. I can say, you know what, I don't think this is the best thing for your child. Not for my research subject, but for your child. So I'm going to stop. Your child is no longer participating in this research. Right? Because I don't think it's appropriate. I don't think that the risk-benefit relationship is acceptable. There's no longer equipoise on my part. Or the people who are running the study, who are looking at the data on a real-time basis, can say, you know what, Group A is doing better than Group B. I don't care that your kid's in Group B and he's doing okay. In general, if Group B is not doing as well, study's over. So there's a lot of, I say this to parents just to let them know, first, that we are looking, that the kid is more important than the research, because he or she is, and that we're looking at this stuff and they can stop anytime they want for whatever reason without consequences. We're going through a phase now where there's less money for clinical cancer research in pediatrics than perhaps there ought to be. And so there are not studies open for every disease. That's a negative thing. We're also going through a point now where we have been so successful with some cancers that there aren't any more earth-shattering questions to ask. And yes, even with something like Wilms tumor, where we cure 95% of certain subtypes and certain sizes, you can always say, let's go for that extra 5%, but it becomes a point of diminishing returns. And those studies are often done better in a small setting rather than a big group setting. And even under the best of circumstances, there is a limit to the amount of money you could spend. So there are situations where there isn't research to be done anymore. But in other situations, we have a limited amount of pool of money to draw from, so we have to choose the highest yield studies. So in answer to your question, if there's a study open, most kids end up on it. There aren't always studies open. But there are patients who are, for one reason or another, are not eligible. There are parents who don't want to do it because the randomization frightens them. There are people, who for whatever reason aren't suitable to participate in a research study. What we'll end up doing is treat them according to the same recipe, because that's the best therapy we have. Most of the studies we have are comparing the best treatment from the last study to something that's different. And sometimes that can be a minor difference or it can be a big thing. But if they don't participate in the research, I'll follow the protocol, the recipe from the last successful study, because that's the best thing I know what to do. And that's all I'm saying to them, is that I'm going to follow that recipe because that's the right thing to treat your child. If you participate in the research, we'll compare the best recipe to one that we hope is going to be better. But we don't know that. It might be better, it might be the same, it might be worse. It's reasonable to let patients and parents participate in decisions about their child. They have a vested interest. And so it shouldn't be the doctor telling you what to do. It ought to be a communal decision. Perhaps the child ought to be involved in it if it involves child research, but there ought to be a discussion. We have to be careful, though, about imposing a burden on patients and on parents to ask them to make a decision that perhaps they are not, well, they almost certainly are not educated enough to make that decision. I don't mean that in a negative way. They haven't been through 4 years of college, 4 years of medical school, 4 years of residency, 25 years of practice, right? It's a rare time that you are taking care of the child of one of your colleagues who maybe has that kind of experience. Most people may be incredibly educated, but they don't know what I know about medicine. So am I imposing a burden on them by asking them to make a decision? And I think that that's it's a very difficult line to walk. You have to be prepared to provide the information to help them through that decision, to perhaps accept the fact that they're going to make the wrong choice, to not be too paternalistic, but also not to require them to make a decision that they don't have the background to make or don't want to make, right? To a certain extent, when you're ill, you want somebody else to make the choices for you. You want your physician to tell you the right thing to do. And so perhaps we should respect that as well, as long as they know that I'm making a choice for you, but I may not be right. I don't consider myself primarily a medical researcher. I consider myself a physician who does research. So if you're asking me what would I advise people who want to go into medicine, that's one answer. If you're in medicine already, do I think medical research is good? Yes. I think academics are the way to go. I think contributing to knowledge is the way to go. It's not the only choice. The other choice can be to spend your time taking care of patients. That's laudable also. That's a reasonable thing to do, and it's a good thing to do. I just personally prefer the idea of taking care of patients and contributing to knowledge that is then going to help people 5 years from now. Does a generalist provide as good care? In a way, yes, because they look holistically and they look at the whole patient. As an oncologist, you come to my office with a lump, and my differential diagnosis includes 12 things having to do with cancer in a lump, right? And it's only after I've excluded those 12 things that I start thinking about other things. You go to a kidney doctor, they focus on the kidney. That's what they know. If you're a hammer, all the world looks like a nail. So a specialist focuses in on what he knows, and a generalist focuses on the whole person. But on the same token, a generalist might not be as attuned to the nuances of diagnosis and treatment of a particular disease as a specialist would be. So I think the correct approach is a sort of gatekeeper approach where you have somebody whose responsibility is to look at the whole patient, to decide what subspecialist they need, and then go that way. But also to coordinate the care, because quite often what you end up with is somebody who's got cancer who, because of the chemotherapy, has now a kidney problem. Well, you bring a cancer doctor into it, and a kidney doctor into it, and a lung doctor into it, and each one of them are saying, do this way, my organ's the most important. And you need somebody who's going to be the overall caretaker, who's going to look at all the things and say, okay, this guy says A, this guy says B, because they're both concerned about different organs. Perhaps we can settle for a combination of A and B, or maybe we need to go to C. But I think it's a very hard thing to do, is to stay up on enough of general medicine to be functional. There's a lot of stuff out there to do. When I was being raised in the 60s, the media was our hero. They were the ones who broke the stories that needed to be broke. And Walter Cronkite was an admirable character, and now not so much. Now we have Fox News, and now we have things that are sensational. And so I think the media does now a disservice in many cases. In other cases, it doesn't. In other cases, it breaks stories that need to be broke. Or it picks up on stories that are broken, that someone else has broken, and brings them to attention appropriately. But more often, to my mind, it is looking for something to be aghast about, looking for something to be angry about, looking for something that's gory and juicy. So I think a lot of what the media does is unfortunate. I don't think there is as much thoughtfulness, and to a certain extent, it's not entirely their fault. We're in a Twitter generation where you can keep people's attention for however many words you can put in a tweet. So you don't have time for the nuances. How many of us open the New York Times and read beyond the first page? You don't read that, the 12-part series. It gives you the necessary background so you understand the issues. You look for the executive summary. You look for the tweet that explains to you so-and-so is bad and so is good. So it's not, yes, in certain cases the media picks up on that and gleefully accepts it, but in other cases, that's all they can do is, they can only do what people will read or listen to. What excites me are new challenges. What excites me is the idea of tackling new forms of research and figuring out how to do them correctly. And by correctly, I mean in a way that gets what we all want, which is the advancement of science, but does so while protecting the people who are contributing, the subjects of the research. I think that that's easier than perhaps we make it out to be, because I don't know that there are that many new paradigms out there. I think you can still apply the things that we know well, the risk and minimization of risk-benefit relationship, equitable subject selection, all those things without, there are some new paradigms. There are certain things we need to understand. That's what's fascinating, is to figure out what's new and what isn't new. But I suspect there's not as much new as we are afraid of. There are not that many. There are lots of things that can be fit into our old models because our old models are good. What scares me, again, is the same concern I had before, that IRBs are still seen as an impediment. And in a lot of cases, many cases, the squeaky wheel gets the grease. And if enough investigators squeak, then either the media or the institution or the sponsors or whoever will answer that by saying IRBs are the problem, IRBs aren't the solution. Again, in many cases, we are a problem, and we need to remember that investigators are not out to hurt people, that they need help to do it right, but they want to do it right. But I'm afraid that to the extent that we are seen as impediments, that there will be changes made to make us less of an impediment, and that's not necessarily in a good way. So that's what I fear. The other things I fear are changes in the way we do things that are not based on ethics, that are based on the particular opinions of a group that influence legislators to the point where they change the rules to satisfy that group, even though it doesn't make sense ethically to do it that way. And it's hard to explain that to people, especially in a tweet generation. It's hard to explain why that's not right. And so I'm afraid that there are going to be changes to the rules that we have, which are not going to protect people, that are going to compromise ethics, going to compromise subjects in the name of protecting a particular group. When I got a phone call from one of my colleagues asking me if I would be willing to consider serving on the board of Primer, my response to her was, how can you even ask that? Why wouldn't I? What an incredible honor this is. This is an organization that stands for things that I think are important. It's a good organization. It does good things. it stands for what my parents raised me. It stands for justice. It stands for beneficence. It stands for respect. The opportunity to serve that organization is incredible. So it was almost a silly question. Would I take this? Why wouldn't I take this? It has to continue to be the premier education opportunity for people in our field. There are other educational opportunities. Premier is the best, has to continue to be the best. It has to get out in the community and teach, not just the IRB community, but the general community. It has to have a role in policy making and legislation. It has to have a role in educating the media and educating the public, not just in educating the people in the field. So it has to be external. It has to be external. It has to go out and do things. We have to be the opinion that folks are waiting for. People in our community, when the NPRM comes out, they want to know, what does Primer think? We should be there, and we should be there for every issue that relates to research ethics, that relates for protection of human subjects. It ought to be, Primer believes this. Good, that's our starting point. You don't have to agree, but that's the starting point. The other thing Primer has to do, and I feel very strongly about, is we have to be a community. This is a place where people who believe this come to be around people who believe this, and to re-energize from those people. We have to find a place where we're safe to talk about these things, where we're comfortable enough to recognize the fact that even within our community, there are some big disagreements. Some years back, I had the honor of being the chair of this annual meeting. And at one of the last the last days, what I was told to do is to ask people from the podium, turn to the person next to them, tell them something you learned. And I got up there and I said, this is what I'm told to do, but that's not what I want to ask you. I want you to turn to the guy next to you and tell him what you now don't know. You came in here knowing, and now you don't know. When I came in for that meeting, I knew that you had to return research results to subjects. And then I went to a debate, and I heard both sides. And now I wasn't sure. And I knew something else, but then I talked to somebody who said, have you thought about it this way? And now I'm not sure. I think that this education meeting serves its purpose when you come out of it with more questions than you went in, because it means you've thought about it. So we are a community. You have to be in a place where you're comfortable, where you can talk to people who fundamentally believe the same thing you do. Beneficence, respect for persons, justice. Maybe have different ideas on how to approach those things. Learn from them. Be comfortable enough to talk to them. We are a community. We are the people who practice research ethics, who facilitate the conduct of ethical research. That's what we are. And that's what Primer ought to be.